Good afternoon. Thank you for taking the time to come to our talk about health equity. We are really just excited to be able to present some amazing speakers that are going to talk to you about some very impactful topics. So we appreciate your engagement, your questions, and hopefully some discussion throughout and also at the end. So we're going to have 4 sections of talks, each followed by a short question and answer, and then we'll have a longer 15-minute question and answer at the very end. So we'll give you plenty of time to be able to ask your questions and encourage you to please ask your questions. When you do, please use the mics in the center of the room. Identify yourself with your name and your institution and your role, and then please try to speak slowly so that we're able to hear and people online are also able to hear. So we're excited to get started. So I'm happy to introduce my co-chair, Dr. Georgine Hergenroder. She is an assistant professor of clinical pediatrics from Children's Hospital of Philadelphia and the University of Pennsylvania. So her health equity take-home point for all of you is the voice of every single person in this audience and listening online is important and powerful. We all have a role in overcoming healthcare disparities and improving the health and well-being of all people with CF. She's going to get us started. Georgine.
Good afternoon, everybody. Just wanted to echo Dr. Laguna's welcome to you all. It's great to see so many people interested in health equity in the audience. This is the presentation disclaimer, and neither Dr. Laguna nor I have any disclosures for this presentation. We would also like to acknowledge the Pawtucket and Massachusetts people on whose native land we're meeting today. Healthcare disparities are widespread among people with CF and occur in many important domains. We know, for example, that people with CF of minoritized racial groups experience delays in diagnosis, decreased eligibility for modulators, delays in starting modulators even when eligible, and higher mortality rates. We know that Hispanic people with CF experience delays in diagnosis, decreased eligibility for modulators, delays in starting modulators even when eligible, earlier acquisition of Pseudomonas, and higher mortality rates. We know that people with CF who have lower median income or who receive public health insurance have worse nutritional outcomes, lower lung function, more frequent pulmonary exacerbations, lower odds of lung transplant, and higher mortality rates. And we know that people assigned female sex at birth have higher rates of Pseudomonas, more prolonged hospitalizations for pulmonary exacerbations, higher rates of CF-related diabetes, and higher mortality rates. I find these trends to be pretty distressing, particularly as a provider for children who either have experienced or are at risk for experiencing all of these disparities. And I want to recognize that many of you in the audience may be feeling similarly, and that these are really challenging, hard topics to talk about, but they affect so many of our patients, and so it's crucial that we discuss these topics. With improvements in newborn screening and the recognition that CF can occur in any race and ethnicity, we are caring for an increasingly diverse CF population. Additionally, more than half of children with CF and 38% of all people with CF receive public health insurance. So the topics that we're going to be discussing today are so critical for the care of all of our people with CF that we have the opportunity to care for. There's been some progress in many of these domains, much of which has been featured during the conference. A few things to highlight are the ongoing excellent effort to improve newborn screening, the improvements in working with our community of people with CF, especially people of underrepresented backgrounds through Community Voice and CF circles. But there's so much more that we need to do, and that's what we're going to focus on with this symposium. So first, you're going to hear an introduction by our parent partner, Raquel Garcia-Cano. Before we hear an overview from Dr. Pittman about what health equity is and why it's important in CF. We're then going to shift to talking about why it's important that our CF workforce reflects the diversity of our patient population with talks by Doctors Despotis and Paula. We'll then talk about barriers to engagement from our communities of color and discuss strategies to improve partnership with talks by Jessica Hudson and Chandra Gordon. And lastly, we'll wrap up with a talk by Megan McGarry about lessons learned from the Hispanic community before final remarks by Dr. Laguna. And I'd like to welcome Dr. Laguna up now for her additional remarks.
Okay, I apologize. I did not introduce myself when I started talking to you guys. So hi, I'm Terry Laguna, pediatric pulmonologist from the University of Washington and division head at Seattle Children's Hospital. So in case you didn't know who I was. So I have the honor of introducing our first speaker. This is Raquel Garcia Cano. I had the honor of taking care of her and her daughter Emma when she was born and diagnosed with cystic fibrosis. We are honored to have her here to now talk about a little bit about her journey. So I'd like to welcome Raquel up.
Hi everyone, my name is Raquel Garcia Cano. I am a former research study coordinator for Adults with CF Center at Northwestern University. And now I am a beautiful mother, a mother to, I am a mother to a beautiful 6-year-old daughter. She just turned 6, who is now living with cystic fibrosis. I would like to start by thanking Dr. Laguna for inviting me here today and to be able to share this platform with me. My daughter's name is Emma, and I was fortunate enough that she was diagnosed relatively early. When I was pregnant with her, I was offered prenatal testing, and I thought it would be a good idea to go ahead and get tested, and it included a panel for CF. When I received the test results, I screened negative as a carrier for cystic fibrosis. However, when my daughter was about 3 weeks old, her newborn screen came back positive for one mutation, which was the Delta F508. And as we all know, it's the most common gene in cystic fibrosis. Given that I had previously screened for CF, I knew right away this gene had come from her dad. At that moment, I tried to hang on to the beacon of hope that she would only be a carrier, as my test was negative. But I was also aware that in Illinois, the panel that we receive for prenatal screening is very limited, and it only includes the most common mutations. And I believe that it does vary state to state. Emma was brought in for sweat testing after that, and when it came back positive, we established her CF care and later got her second mutation, which is the 3299A2C, a rare variant that's found in the Spanish and Portuguese ancestry and their descendant communities in Latin America. Upon further digging, I've come to realize that the most common mutations of those screened in prenatal testing are those that are common in CF communities of Northern European ancestry. Other populations, global populations, and of those of mixed ancestry, such as those of Latin American ancestry, are most likely missing early CF diagnoses with these common tests and unintentionally creating a disadvantage and health disparity. We live in a time in which institutions such as NIH are calling for precision medicine, given significant advances in sequencing and genetic testing. I advocate today for a more inclusive, curated database of genetic mutations and better access to gene sequencing to better capture the susceptibility of CF mutations in the diverse worldwide populations. With Emma's diagnosis, I was fortunate enough to have basic knowledge of CF. As I mentioned earlier, I had worked with adults with CF. And I learned not only through research, but also from those adult patients. But it's a whole different ballgame when you become a parent and have to raise someone with CF. There's always other challenges. To learn about CF while learning to be a first-time parent is quite overwhelming. My family knew something about it because they would ask me about what I would do for a living. But the rest of our extended families, including those of Emma's fathers, their knowledge was very limited for CF. CF is already a rare disease, but it's even more rare within the Latin Hispanic community. When I went back to Guatemala, no one in our extended families, including Emma's fathers, had any knowledge of CF. And I was astonished to learn that within the public health care system, there was only one vest machine that had to be shared with the entire CF community, and many of those who have unconfirmed diagnosis due to their lack of resources. I can't help but wonder how many people have misdiagnosed, especially those in those communities with limited health care that are left untreated. My daughter's father is a carrier for 2 genetic mutations for CF. He never knew this until my daughter was diagnosed. Had my daughter carried his second gene, she could have easily missed diagnosis altogether. And if she did eventually get diagnosed, she would be screened out of most research studies for carrying 2 rare variants and would potentially be left out of receiving any of the CFTR modulators, such as Trikafta and Kalydeco. I also recall a conversation I once had with the PI I worked with, Dr. Jane, and we were looking to recruit for research. And I noticed that it included only those with the most common mutations. And I recall asking him, well, what about all the rare alleles? How do those get studied? His response was, they don't get studied much because there is not enough of a sample size to have statistical power to determine significance within those variants. I thought to myself, this is very unfortunate, but now it all hits differently. Having almost missed diagnosis makes me think about it a little more. Perhaps if we change the way we screen families, we could potentially reduce the amount of missed diagnosed CF population. Consequently, we could also be identifying a larger sample population to study and to get the proper treatment for those in the understudied groups as well. I absolutely love the culture and the care team that we receive at Lurie's in Chicago. They have an incredible support system, and they have developed a great system in helping me as a parent and caregiver of a child with CF. Emma's treatments and medications were all done in increments, prioritizing and allotting time for us to adjust to Emma's routine. A caring team is always essential into aiding how to best raise a child with CF and allow them to be successful. But as we all know, there's only so much you can take in a clinic visit. And dealing with a progressive disease requires not only a great medical team, but also a supportive community that is living it as well. This is one of the challenges that I have faced coming in as a parent of a Latinx CF community. Early on, I found myself on several social media platforms, and it didn't take long to notice that there is no support geared towards the Latinx and Latin American communities in the CF community. I often feel like my family is a needle in a haystack, So how do non-white families of CF children identify with the community for support? While I have found the CF community to be incredibly supportive, and I do believe that it does have the potential to become even stronger by advocating for the inclusion of those in the underrepresented minority groups, not only in diagnosis, but also within the community itself. It's important that we foster this growth with sensitivity and ensuring that all voices feel heard and supported. Emma and I are really grateful for our current community, and she would like to share a few words in a video.
Hi guys, thank you for taking care of me and taking care of other kids, and that makes me happy because to make them feel better, you make me happy because I like it when people be happy and get better. I love you. Bye.
Thank you, Raquel. I'd now like to welcome up Dr. Jess Pittman, who is an associate professor at Washington University School of Medicine. She is also the DEI faculty lead at WashU Med Office of DEI, associate program director for DEI, and St. Louis Children's Hospital Pediatric Residency Program. Dr. Pittman's health equity take-home point is that we all have the power to make change, however small, to improve health equity for our patients. Even small changes are meaningful and can have a ripple effect.
Hi, everybody. Thank you. I will be kicking us off, hopefully laying the groundwork for the rest of this session. Sorry, hard to hear? Is that better? Okay. I'll be kicking us off, hopefully laying the groundwork for the rest of this session, talking about equity in CF. Here is our conference disclaimer, along with my own, that the topics that we're talking about today may make you uncomfortable, and that's okay. We encourage you to sit with, interrogate, and lean into that discomfort so we can do a better job for all of our patients. I have no relevant financial disclosures. So this is a pretty simple talk. We're going to talk briefly about health disparities, and then we're going to spend the bulk of this talking about what we can do to make things better. Before I do that, however, I'm going to give you two abbreviations that you'll hear throughout this session. The first is BIPOC, which stands for Black, Indigenous, People of Color. This is an umbrella term that's used to speak to the marginalized experience of individuals who identify as other than white, non-Hispanic, while also emphasizing the added historical and current harm to Black and Indigenous communities in particular. The second is underrepresented in medicine or underrepresented in research. This speaks to racial and ethnic identities that make up a smaller percentage of the physician workforce than their percentage in the general US population. And it's defined by the NIH and AAMC as individuals identifying as Black, Hispanic, Native American, Native Hawaiian or Pacific Islander, Native Alaskan, and mainland Puerto Rican. All right, let's jump in. We all know that inequity and disparities exist in CF, and in fact are the status quo when it comes to medicine and health in general, and unfortunately our society at large. You heard much of this already, so I will just briefly say that we know that marked disparities exist in CF outcomes by race and ethnicity, socioeconomic status, and gender. People from lower SES with CF have increased morbidity and mortality. Black and Latina people with CF have a nearly twofold higher risk of death before age 18 than non-Hispanic whites. Black people with CF average an FEV1 16 percentage points lower than their white non-Hispanic counterparts, even using our older biased and racist reference equations. BIPOC infants have later presentation to CF clinic, even in the era of newborn screening. And people with CF assigned female at birth have a higher frequency of exacerbations and increased mortality. When we dive into that newborn screening data a little bit more, we know that there's decreased sensitivity of newborn screening in marginalized racial and ethnic populations, which leads to overrepresentation in the false negative and delayed diagnosis groups. As you can see here from Dr. McGarry's work, where our CF population is approximately 85% white non-Hispanic, but that group makes up only 68% of the false negative and delayed diagnosis group. whereas essentially every other marginalized or racial and ethnic identity is overrepresented in that delayed diagnosis and the false negative group. Similarly, when we talk about modulator eligibility by genotype, it is significantly lower in marginalized racial and ethnic populations. Non-Hispanic whites with CF are eligible for modulators a little bit over 92% of the time, whereas Black individuals with CF are eligible for modulators less than 70% of the time. Hispanics around 75%, and all other races around 80%. So those are the inequities. What do we mean by equity itself? When we're talking about equity today, we're talking about equities of outcomes as well as equity of individual experiences. We're not talking about equal or fair treatment. If our goal is equity of outcomes and experiences, that comes by giving people what they need to achieve that desired outcome, acknowledging and addressing barriers, and empowering and inviting individuals to participate in their care. I'm a pediatrician, so this is one of my favorite diagrams around inequity. Here we have two little kids who are essentially identical. There's an apple tree, and the apple tree is tilted towards one child. So the child on the left is going to benefit when those apples fall from the tree. When we think about how we talk about people who we focus on in our society, it tends to be the folks who already have advantage and are more visible. So if we say we want to help these kids get apples and we're going to treat them the same, likely we're going to center the experience of the child on the left and then give them both the same ladder. So now the child on the left can access apples whenever they want to, and the child on the right is up higher and still staring and hoping something drops their way. If instead we recognize that these two children have different experiences, are experiencing different barriers, and have different access, then we recognize that in order to get to an equitable outcome, we need to give them different things. So the child on the right gets a taller ladder so that they are able to reach the apples as well. And then finally, if we really want to make change, then we work towards justice. We recognize that the problem is not the children themselves, the problem is the system. The system in this case is the tree. So if we straighten the tree and redistribute the apples so that they're equally spaced around the tree, then these children do have equal access, and it would actually be okay to treat them equally. If we recognize that barriers exist for some of our patients more than others, then acting with a presumption of equality is inadequate. We know that equal treatment does not guarantee equal outcomes and actually has the potential to perpetuate and worsen prejudices and disparities. Simply put, equity is achieved when a person's race, ethnicity, or other marginalized identity does not predict their experience or outcome. We can begin to work towards equity when we start to interrogate the system, acknowledging the systemic and structural barriers many of our patients face. This is a schematic of what goes into our overall health, and you can see that we spend a whole lot of time focusing on the 10 to 20% of health that is defined by healthcare, but much less time thinking about that other 80%, which includes socioeconomic factors, physical environment, and health behaviors. Another way to think about this is whether we focus downstream or upstream when we're talking about inequities. We tend to focus downstream on looking at inequities by individual disease, perhaps by risk behaviors, instead of looking upstream at the social and institutional inequities that exist. Focusing upstream might have a much larger impact for our patients across the board than spending our time focusing downstream. All right, we've talked about equity. Next, we need to recognize that the disparities that we see are the result of racism and other isms, not of race. And we're going to talk about practicing racism-conscious medicine as opposed to race-based medicine. I usually spend at least an hour talking about this. Here I have one slide. But racism-conscious medicine starts with the foundational knowledge and acceptance that race is a social construct, not a biologic one. Race is a personally held identity, as well as an identity that others may presume of you based on your appearance, and those may not be in concordance. Race is also not a binary. I like to say that it's a sphere. Skin color, hair texture, eye color, country of birth, ancestral origin, genetics, all of these go into play for how we identify when it comes to race and ethnicity, as well as how others see us and presume our identities. Despite the fact that race is a social construct, racism is very real. And it is actually the impact of racism that drives many of the disparities that we see across outcomes. This racism includes barriers caused by structural and systemic racism, individual trauma caused by systemic and institutional racism, as well as individual bias, and differential treatment caused by individual provider bias. And only when we're willing to interrogate and unpack all of those, the barriers, the individual trauma, and the provider bias, will we actually make headway in addressing these inequities. We also need to acknowledge that genetics and genotype do not fully explain the degree of disparities that are seen by race and ethnicity, nor do socioeconomic status or barriers to care. Trauma and bias are really important here. I'm going to shift briefly to talking about the CFF Communities of Color report. You're going to hear a lot more about this later. This was a multi-year project to better understand the experience of people of color with CF. And the key take-home points were representation, individual healthcare provider bias, and trustworthiness. When we talk about representation and accountability, first we need to think about our implicit bias and imagery, both in our textbooks as well as in the literature facing the public and patients. We need to recognize the idea of tokenism and DEI tax. When do we choose to engage with our BIPOC patients? How? Is it longitudinal or is it a one-off? And does it benefit them or does it benefit us? And finally, we need to recognize that as a whole, as a scientific community, we spend a lot of time using a passive voice to belie the role of science and academic medicine in perpetuating inequities and bias. This is an example from the 2023 Patient Registry Report. You can see here it says the CF population is growing more diverse every year. That's true, but I would argue that a better way to put this is, as we address diagnostic bias and improve genetic testing, more BIPOC individuals are being diagnosed with CF every year. The former implies a natural and passive process that just happened. The latter acknowledges that these patients have always been there, we just haven't been looking for them. Next, we need to think about interrogating our own individual bias and privilege. And this is my challenge for you all today. We can't do any other work until we are willing to look internally and recognize that we all have bias and we all have areas where we can improve. Hopefully everybody here knows that bias are assumptions made about an individual or group that are sparked automatically. And privilege is a special right or advantage granted to a particular person or group. We should recognize that privilege in one space does not negate hardship that you may have faced in another space. It just means that that privileged identity did not make it harder for you to access or achieve what you needed to. We also need to recognize that everyone in this room holds privilege or we wouldn't be here. And finally, blind spots are areas where privilege and bias negate another's experience by not acknowledging the potential for that experience or any experience but one's own. Together, bias, privilege, and blind spots allow us to act without empathy, imparting judgment towards the individual as opposed to interrogating the system. And this looks like us saying, I can't believe they showed up late, versus I'm so glad they were able to make it, or asking a patient why they're not taking their meds, as opposed to asking what regimen is realistic for them. And finally, we need to think about trust and recognize that trust must be earned and it's our job to do it. Patient mistrust is often cited as a reason for low BIPOC representation in research, particularly for Black patients. This is often referred to in a way that is removed and historical. Black people don't trust research because of Tuskegee. That blame or responsibility is typically directed at the patient or family and almost made to make them seem unreasonable in having those beliefs. Instead, we need to recognize that science and medicine have been used to and continue to be used to justify and perpetuate racism and other harms. And our lack of recognition of recent and ongoing racial trauma and bias allows for that judgment and perpetuation of harm. We need to acknowledge that traumatic experiences and malfeasance for our patients are real, pervasive, and personal, and consider our institutional histories as well as individual experiences in our institutions. And while we do that, we also need to avoid assumptions of a single experience based on a racial identity or other marginalized identity. And again, the onus must be on us as providers, the individuals who hold the power to build trust in any fractured relationship, regardless of identities, but especially when dealing with patients and families who hold marginalized identities. We must make additional and intentional efforts to build trust in the clinical setting before even broaching research participation. And we can do that by practicing culturally humble care. And this turns from they don't trust us to we haven't earned their trust yet. All right. We're going to briefly touch on diversity and inclusion. So we achieve equity by truly valuing diversity, and we do that through inclusive excellence, which means recognizing the benefit of a broad diversity of identities, perspectives, backgrounds, and experiences in improving clinical care, education, team experience, and innovation for all individuals. Diversity in our CF team improves equity in treatment, policies, and experiences by limiting blind spots, offering multiple experiences and perspectives, and challenging the status quo. Diversity, however, is also not a binary. This is not about checking boxes. We all hold multiple identities, visible and invisible, marginalized and holding power. These identities can be contradictory or in conflict. And within any identity, there are myriad experiences within each identity group. Our identities and our privilege shape our lived experience, making each of us unique. And so when we talk about diversity, it's not about checking boxes or filling categories. It's about recognizing that building a breadth of identities, perspectives, and experiences in any space helps us all and makes us better, and we should continue to strive for ever more diverse spaces. Similarly, team diversity is not a binary. Team diversity is not simply about finding providers that look like their patients, because again, there is no singular minority experience. We know that identity concordance improves outcomes, but it doesn't erase bias, and a shared racial identity does not guarantee a better connection. Furthermore, full identity concordance is an unachievable goal. Even if our workforce had the same racial and ethnic makeup as our patient population, would you say only Black providers can see Black patients? Only Asian providers can see Asian patients? This also ignores the myriad other identities, again, visible and invisible, that we all hold. Full identity concordance with patients and providers is just not achievable, and instead we must recognize and embrace that we will always be working across identities. All of us will be. And so instead, we need to build team diversity to promote inclusion and belonging, broaden our perspectives and build empathy, promote innovation, and again, improve care for all of our patients, regardless of their identities. And finally, patient diversity is also not a binary. This is from the 2022 Patient Registry Report. Race is reported as mutually exclusive, white, Black, and other. How we present race and ethnicity matters. Racial categories simply aren't mutually exclusive. I identify as Black biracial. I don't know where I fit in this table. The presumption that any minoritized identity leads to poorer outcomes centers white as the norm, and lumping racial identities negates differences in experience and potential differences in biology. And I've said it, I'll say it again, even within a racial or ethnic identity group, experiences, barriers, and risks vary. There is no singular experience for any identity group. So, what can we do? That's what this session is about. I'm going to challenge you with where you can start. You can start by trying to practice racism-conscious medicine, and that begins by interrogating your individual biases and blind spots, recognizing what patients we're willing to give the benefit of the doubt to, stay a little bit later for, make a phone call for, spend more time with, and what patients we might walk into a room with a negative attitude or a defeated attitude already. We need to question the system before placing blame on the individual and do our best to offer alternative narratives to ourselves and others that avoid judgment. And we need to recognize and address patterns of behavior in ourselves and others that may impact our patients and drive our outcomes. We can practice cultural humility by sharing power whenever possible, practicing empathy and perspective taking, and taking on the responsibility to build trust with all of our patients. And finally, we can work to truly value a diversity of identities, experiences, perspectives, and backgrounds by not assuming any experience based on any identity, treating every person as an individual worthy of building a trusting relationship, and asking questions to gain shared perspective and understanding. And with that, I will be open for questions. Thank you.
So I'd encourage you, if you have questions for Dr. Pittman, to go to the mic and remember to introduce yourself, your institution, and your role. If you're online watching, please make sure you enter your questions. We don't have any yet, but I'll keep an eye on that.
Yeah. And just to start out, Dr. Pittman, firstly, thank you so much. What does working across identities or culturally humble care look like in this setting?
So I think part of it is really, it goes back to asking questions and not making an assumption. So when we have patients who maybe struggle to make visits or struggle to take medications, or we're seeing suboptimal relationships, asking more questions, making that effort, really doing our part to understand what's going on. It also, when we talk about power sharing, that really means we all know that there's not one right way to practice medicine, right? There's a whole spectrum of how you could choose to deal with any one thing. And so I do my best to offer patients and families as much of a spectrum of options as I can, right? Do you want to attack this aggressively or not? Do you want to come back soon or not? Obviously within the bounds of what we feel is safe, but that really empowers our patients to think about how they want to think about their care, and it recognizes the barriers that we may not see that exist for our patients as well.
I know you guys have a million thoughts going on in your head, so I'm going to give you another second to think about that, and I'm going to ask you a question, Dr. Pittman, before you go away. So everybody is on their own journey in how to become an anti-racist, or how to provide more culturally, practice more cultural humility. So I guess, what advice would you give to people in different stages in their journey? How do you start? How do you keep the momentum going? What are some things that everybody in the audience should be thinking about?
Yeah, I think the two things that I try to focus on, one, are patterns of our own behavior. So we all know when we're in a room and we are shutting down, right? I'm asking more closed-ended questions. I'm moving towards the door. I'm getting frustrated with a parent or a family. And the challenge for us is to recognize that that's on us. Right? It's not a parent's job to make me feel better. I hold the power in this relationship, so it's my job to work harder, to put my laptop down, to make eye contact, to ask more questions, to say, I feel like I'm missing something. Can you tell me more about what's going on? So I think part of it is recognizing our individual patterns of behavior, and then thinking about where they are as a group, right? So when I notice a pattern of behavior around a particular identity, or a particular, whether it's an insurance status or something like that, then I can retrain my brain to act differently, to think differently before going in the room. And the second is to recognize where our practice patterns may be harming our patients, particularly causing more inequities, and to start challenging those. One example I give from asthma is we typically prescribe asthma inhalers twice a day, but there are some that are once a day. And in reality, those of you who have kids, giving medication twice a day in ad infinitum is like impossible. And so I ask my families, it's usually written twice a day, but I've had good luck prescribing a higher dose just once a day. What would you prefer? And I do that for everyone, regardless of what I may see or not see, where I may consider their barriers, and I give them the choice and empower them to make that choice. Thank you, Jen, and she's not a plant. The short restatement of her question was, what can we do to take this outside of this room, both for folks who are sort of higher up in the hierarchy and folks who are perhaps lower in the hierarchy in terms of trainees. So one is, I think, it is not hard to offer an alternative narrative, right? And that's a way to call people in and correct them gently without saying like, wow, what you said was racist, right? But so when I think, which I often do, oh, they showed up 20 minutes late, because we all do, we're human. I can tell myself, wow, I'm so glad they showed up, right? And then the next step is to actually say that out loud so that everybody in clinic hears me say, I'm really glad they made it. I know they were worried at their last visit, right? So I'm gonna give them a positive framing. I'm really glad they're here, right? I know they're struggling, and I'm so happy they've made progress in their care. There's always a way to phrase things with more positivity to remove the judgment that is implicit in so much of how we actually talk about our patients behind the scenes. And the second is, particularly when talking to higher ups, first of all, I'm happy to come give a talk. But secondly, I think it's just starting to be bold enough to speak to the inequities that we see, or the inequities that we see may have happened. Most of the time at this point, inequities that are persistent are in place not because of intent, but because this is how structural and systemic racism work, right? If you function in a racist system and don't acknowledge and interrogate how things that you do are going to perpetuate racism, they're just gonna do it, right? Our clinic late policies, our hours, the hours that we answer our phones, these all perpetuate inequities along racial and socioeconomic lines. And so when there's a policy coming up, if there's the opportunity to say, hey, have we thought about how this is going to affect our patients who don't have access to a phone during the day, or who use public transportation, or whatever the inequity might be? It's a chance to offer that voice, because most of the time it's not done with intent. It's because the people who are sitting in the room making the decisions are coming from that space of privilege, and that is a blind spot that they hold. Asking the question may not make the policy change immediately, but it gets it out there, it puts the bug in their ear, and then it may actually get the policy changed later. I think I'm over time, so thank you, everyone.
Thank you so much, Dr. Pittman. I'd now like to introduce Dr. Alex Despotis and Dr. John Paula. Dr. Despotis is currently completing her combined pediatric and pulmonary and adult critical care fellowship at the University of North Carolina, Chapel Hill. And her take-home equity message is that Around a third of our physician workforce and trainees report experiencing discrimination in the workplace, indicating that we need to work towards treating our colleagues as well as our patients with more empathy and inclusivity. And Dr. Paula is actually going to be going first. So Dr. Paula is an assistant professor of pediatrics at Lurie Children's Hospital, and his take-home point is that the task of achieving equity is a large undertaking that may seem overwhelming at times, but do not get discouraged. Continue to stay focused on how you can make change in your space, listen to others' experiences, lift up those around you, and advocate for your community and yourself.
All right, thank you. So, hello everybody, I'm Dr. John Palo. I'm a pediatric pulmonologist at Lurie Children's Hospital. I have the honor and privilege to now be taking care of Raquel's daughter, Emma. And today, Dr. Despotes and myself will be talking about the lack of diversity in our CF teams, lessons from a CF physician workforce survey. Here's the disclaimer. I have nothing to disclose. And so for my portion of the conversation, the objectives that I'm hoping to achieve is to understand the importance of diversity in the workforce, explore how to improve diversity within the healthcare workforce pipeline, and evaluate strategies to retain a diverse workforce. So why exactly should we care, right? So one of the main reasons we should be caring is because of the changing demographics here in the United States. Over the last decade, our diversity index, which is the probability of picking two random people in the population and then seeing if they have any racial or ethnic concordance. And so that diversity index has been increasing over the last decade. And so it's very important that we have a workforce that reflects our ever-changing community. Now, there are studies that show that a diverse workforce and people inside that workforce help broaden perspectives and decision makers, or basically the perspectives of the decision makers, and hopefully become decision makers themselves. We also have data to show that diversity improves work output and healthcare delivery. And finally, for the leaders in the room, or to bring back to leadership, it's been shown over and over again that diversity in the executive team and the C-suite actually improves financial performance. So let's first touch upon some healthcare outcomes. So there are a few studies out there that look at diverse medical teams, and when you have a diverse medical team, you actually have more accurate diagnoses, you have improved accuracy of clinical decision-making, you have higher patient satisfaction, and you have greater patient compliance with medication and recommendations. So overall, you're going to have better health outcomes when you have a more diverse medical team. And so McKinsey is a consulting firm that's been looking at diversity, racial and ethnic diversity, as well as gender diversity in executive teams over the last few years. They publish a report every year or so, and they're now on their 4th edition, with the last one published last year. And what they've noticed in each, this is actually from their last report, that companies in the top quartile for both gender and ethnic diversity in executive teams are 9% more likely to outperform their peers. And with each edition that they publish, they do show that greater diversity in the board of directors actually leads to greater financial performance and outcompeting of their less diverse counterparts. And the graph below is actually a representation of both women and ethnic diversity in the executive team suites. And we have some movement since 2018 to 2023 that we do see an increase in both women and ethnic diversity in executive teams. So how can we ensure a diverse workforce? And so this is kind of the very classic paradigm that we all think, right? So we want a diverse medical school, which then we're kind of recruiting for diverse residency. And then from residency, we want a diverse subspecialty fellowship. And then also we want a diverse workforce in faculty. But I just also want to zoom out of this very classic paradigm and think about this on a broader scale, that if we don't provide our children that are coming up with greater access to higher education or opportunities, that we won't necessarily have any opportunities to recruit anyone in graduate education or beyond. And so investment at a young age, as young as even in kindergarten, is going to be kind of step one to ensure that we have this diverse workforce. And so this is from 2019, there was a survey out to pediatric residents by the AAP looking for what exactly residents are considering when they're looking at subspecialty training. And so the first thing that they, basically they're looking at what they think is essential and what they think is unimportant. And so access and exposure to subspecialty training or teachers during residency programs they found to be essential and very important. Also having mentors during residency they also found important. And one other thing I wanted to highlight here is that they found unimportant or somewhat important the level of educational debt. And I think this speaks to the cohort, like the privilege of this cohort, meaning that we know that racial and ethnic minoritized and marginalized communities have greater burden of educational debt and find that to be an important factor when deciding career choices. And so this, I think, speaks to the relative diversity that's already in our existing cohort. And so there are some institutions that are out there that are working to improve diversity, especially within the recruitment process. And so there are some intentional initiatives that are out there. They're looking for a more holistic approach. And so rather than relying on test scores or prestige, you're looking at the individual and what perspectives they can bring, what experiences they can bring to your program, and making sure that that's reflected in the recruitment process. There also is outreach opportunities, so conferences, second look programs, travel rewards for interviewees that may not financially be able to come see your program, as well as social engagements with the candidates, specifically targeting marginalized and minoritized communities. So I think in the current political environment that we're living in, it's would be disingenuous to not talk about this past legislative cycle, where there has been over 100 bills across greater than 30 states in the US targeting DEI initiatives. Right now, these bills are getting in the way of public funding for universities and DEI programs, trying to dismantle the diversity, equity, inclusion of individuals, which is going to be an incredible hindrance to this pipeline that we're trying to not only foster, but protect. And so this is a map of bills that were introduced in blue, passed at least one chamber in the state legislature is in yellow, and then in orange is bills that have been enacted against DEI. So once we have our workforce that we have that is diverse, how exactly do we retain this? And so not a small task, but addressing discrimination in the workplace. So refusal of patient care by patients based on race and ethnicity, use of racial epithets in the workspace, structural biases preventing career enhancement are all things that need to be addressed to make sure that we retain this workforce. Also preventing the burnout due to minority tax. That concept of, come June, I get a lot of emails from both the department as well as the division that, since I'm part of the LGBTQIA community, can I do this? Can I do that? And can I be on your social media? All, I think, with good intentions, but I don't necessarily get any extra time or funding for that. And so being, cognizant of tapping that same person over and over again, which could lead to burnout. Also, you want to create a diversity-friendly environment. And so this is key to avoiding frictions that come with this change. So this kind of leads to the creation of what is called a safe space. I'm sure we've all heard of this concept. There are a lot of definitions out there. I like this one from the Advocates for Youth, which is an LGBTQIA organization. And so what they define a safe space as is a place where anyone can relax and be fully self-expressed without fear of being made to feel uncomfortable, unwelcome, or challenged on the account of biological sex, race, ethnicity, sexual orientation, gender identity or expression, cultural background, age, or physical or mental ability. A place where the rules guard each person's self-respect, dignity, and feelings, and strongly encourage everyone to respect others. And so when you create this safe space, you then create the concept of psychological safety. And there is a lot of studies showing that when you have a psychologically safe environment, team members are more engaged and motivated. You have better decision making. It fosters a culture of continuous learning and improvement. The Harvard Business Review actually did a study that showed that who is on the team matters less than how the team works together. And so when you don't have a psychologically safe environment, then you have an increase in stress, burnout, and turnover. So I just kind of end on this. And so I think when everyone thinks of diversity, they always think of racial and ethnic diversity, which is very important, but there are multiple identities that everyone possesses. And one marginalized community that doesn't always get recognized, especially in the healthcare space, is the LGBTQIA+ community. And this is going to become ever more present because as it's becoming more socially acceptable to become out, or basically be out, we're also seeing an increase in individuals that identify as LGBTQIA. And so greater than a quarter of Gen Z adults right now identify as part of this community. A third of Americans say that they've been discriminated against and in their career development. A third of members of the LGBT community employees have left their job due to lack of inclusive workplace. And then half of workers that identify as LGBTQIA aren't even out to their supervisors for fear of hindering their career progression. And I think what's even more appalling is that about 1.6% of managers in the US are LGBTQ women. And so just a plug here. And so right now we're looking specifically in the cystic fibrosis community, exactly what it means to be both LGBTQIA+ and having cystic fibrosis. And so this is the Pride CF study, which is currently ongoing. You probably have heard about it in other sessions, but this is a fantastic team that we're looking at that intersectionality of what it means to be part of that community and have a chronic illness. And so in summary, a diverse workforce improves financial performance and health outcomes for all. We need intentional initiatives and outreach to recruit a diverse workforce. And then to improve the retention of a diverse workforce, we need to address discrimination and prevent burnout. And this can be by the creation of a safe space and like the implementation of a psychologically safe environment. And so these are the references of all the different studies I was talking about. And then anyone that's interested to learn more about Pride CF, you can go ahead and click on this QR code to sign up for our newsletter. All right. And so Dr. Despotes is now going to, or Despotes, sorry, I keep putting a Spanish accent on that, is going to now kind of talk about what the actual diversity in our CF team workforce looks like.
First of all, apologies for my voice, but thank you so much for the opportunity to speak. My name is Alex Despotes, and I'm in my last year of combined pediatric and adult pulmonary and critical care fellowship at UNC. Disclosures related to this presentation, this work that I'll be presenting was funded by the CF Foundation. So now that we've heard from John about the importance of having diversity in the healthcare workforce, we're now going to talk a little bit about some of the key findings from the recent CF Physician Workforce Survey. So thank you all who participated in that. And I hope to illustrate the ways that we sort of found a lack of diversity in some realms, gaps in equity of promotion and leadership, and then a greater need for inclusion in our workforce. So I'm going to start by describing why we did this study. This study grew out of the fact that we really have never described our CF workforce, and we really don't know if it's adequate to care for our current aging and changing CF population. And that is true in terms of both the number of subspecialists, but we also realize we don't know what other perspectives our providers are bringing to our care teams. And I do want to highlight these are U.S. physicians, and they are just physicians. This is a small part of our current CF care team, and so it'll be important to extend this kind of work to the other members of our multidisciplinary teams. But we started with our physicians on our teams, as well as the increasing number of subspecialists outside of our direct teams that our patients interact with. And then we were also interested in surveying physician trainees who might be entering relevant specialties and subspecialties, getting to the point of, are we recruiting a diverse workforce into our, a diverse group of trainees into our workforce? So this was an electronically distributed Qualtrics developed survey that was sent out via email through the CFF physician email lists, as well as emailed directly to program directors earlier this year. And we had 227 physician responses from our current workforce, as well as 118 physician trainee responses. And I'm going to start by highlighting some of the demographics of our workforce. So we had a higher percentage of women respondents in our current faculty. And to get to John's point, we had a small number of individuals that didn't fit into those binary gender categories in survey boxes. So illustrate some of the limitations of doing surveys like this. We had men that were significantly older in our respondent group compared to a group of younger women, and so more junior women faculty currently and more senior male faculty. And as far as race and ethnicity, we had a predominantly white, non-Hispanic group of providers, and I've shown both our current faculty respondents as well as our trainee respondents here, in addition to the recent registry data. Not that the goal is one-to-one concordance, as we've heard, but just to kind of see where we are. And I did want to highlight that we had very small numbers of respondents in certain groups. And so I think it's important when taking these findings that we really can't speak to the experience of some of the individuals in our workforce because of those small numbers. So what are some of the experiences that our current faculty have had in our workforce? One of the biggest findings that we had is that 35% of our physician workforce has experienced discrimination in the workplace. And so this is a group of our colleagues here. This is our workforce here. And so you yourself may have had this experience, and many people in this room have had these experiences. Interestingly, 19% weren't sure if they had had this experience, which in my mind made me wonder if taking the survey, they then reflected back on experiences and were second guessing some things. And the experiences have not been equal within our workforce, with women being nearly 10 times more likely to experience discrimination compared with men faculty. When looking at race and ethnicity, we found that non-white and Hispanic respondents had a trend towards experiencing increased workplace discrimination. We thought it was important to look at markers of career advancement, promotion, leadership roles, because all of those factors are important in determining who gets to those leadership positions, who is going to be in a position to be able to help us support changes on broader scales, who are going to help change our workforce and our care for our patients. And going along with there being a higher proportion of older men faculty, those men had higher levels of promotion, which was not surprising compared with women. But when surveyed about the barriers to promotion that people had experienced, women experienced significantly more barriers to promotion compared with men per person. And 31% of women actually specifically reported gender bias as a barrier to promotion. 5% said that racial or ethnic bias had been a barrier to promotion. When we looked at the number of leadership roles held, although there were no significant differences in the number of current leadership roles held by race, looking at prior leadership roles held, non-white respondents were held significantly fewer prior CF leadership roles, indicating that it's likely harder for those individuals to get their foot into the door, into that first position of being in a leadership role within CF. John highlighted the importance of workforce retention. We found that 21% of our workforce is likely to retire in the next 5 years, while an additional 14% are likely to reduce the amount of time devoted to CF clinical care. And so when thinking about experiences such as discrimination in the workplace, we looked at some other factors that could put some of our members at risk. We found that women faculty had lower odds of career satisfaction, lower odds of successful work-life integration, spent increased time on home responsibilities, as well as experiencing higher numbers of outside stressors. So certainly different experiences that might impact their ability to devote as much time to CF care or take on that extra leadership role, or really be able to stay in our workforce in the same way. We found that Hispanic and non-white respondents had trend towards reporting more workplace stressors. And additionally, Hispanic respondents reported significantly more outside or home stressors per person. And I think we can all agree that the current political climate and global events might be influencing the experiences of members of our workforce in different ways. And so again, might impact the ability to retain a diverse workforce when you compound that with the experience they're having with discrimination in our workforce. And then because of the small numbers of non-white and Hispanic respondents, we may not have been able to assess the differences in their experiences of things such as burnout, career satisfaction, work-life integration, and other outcomes. What about our trainees potentially entering into our workforce? We found that unfortunately the experience of discrimination begins very early, with 27% of trainees already having experienced workplace discrimination, despite only being in the healthcare space for a few years. Interestingly, the experience of discrimination for trainees had more regional variation than we saw on our faculty data, where there wasn't much of a difference. And so I'm not sure if this speaks to different training institution cultures in different regions, and I'd be curious to know if others have thoughts on this finding, since it was different from our faculty findings. And then, unfortunately, we also saw the same pattern reflected in our trainee data, where women trainees were significantly more likely to experience discrimination in the workplace than men trainees. And then trainees of minoritized races were 4.4 times more likely to experience discrimination. One of the main focuses of the trainee survey was to gauge factors as far as potentially predicting interest in CF as a career. And we found that those who had adequate time to explore CF as a career had a higher odds of wanting to make CF a major focus of their career. But just like we saw with other experiences, not all things were the same within the trainee respondents. White trainees had 2.4 higher odds of adequate time to explore CF as a career compared with non-white trainees. And so I think there's a lot of potential threats where we're not going to be able to recruit a diverse workforce. So some of the key survey takeaways is that there is a lack of racial and ethnic diversity among surveyed US CF physicians as well as trainees. The experiences within the workforce are not the same, with over a third of the current workforce experiencing discrimination, and those who are of racial and ethnic minoritized backgrounds and women are experiencing higher rates of that discrimination in the workplace. And these and other findings influence leadership in our care teams, as well as threaten the workforce pipeline, overall diversity, and then workforce retention. And I just wanted to pause here for a minute and have us all think about the experience of workplace discrimination, because this is how we're treating each other. These are maybe experiences you've had or that your colleagues have had. And so if that's how we treat each other, it's not surprising that other people on our care teams might not always feel heard or like their perspectives aren't being valued. And then it's also no wonder that our patients are having these experiences too and may not feel like their perspective is valued. So again, we're all colleagues here together, and so I hope we can take that away from this together to bring forward. So as far as next steps, we need to continue to define the scope of the problem, extend this work to others in our multidisciplinary teams. Again, this is just physicians. And then we need to follow up these survey findings, because again, these checkboxes are really not adequate to describe the diversity in our workforce. And then we need opportunities through the CFF to continue to do this work. Again, this work was funded by the CFF. But beyond just defining the scope of the problem, we're really past the point of just raising awareness, because our colleagues and our patients deserve better. And then I encourage you to attend the Workforce Symposium, where more of our results will be highlighted tomorrow morning. It should be some great discussion, and I look forward to the questions and discussions here today.
Thank you so much, both Dr. Despotis and Paula. We have just under 1 minute for questions, and of course the Q&A at the end. So I can start us off. Dr. Paula, what do you feel are some tangible next steps we can do to really improve the diversity in the workforce?
So I think that's a complex question with multiple answers, potentially. And I think it really comes down to, us as individuals, what exactly are you interested in? I think one easy thing is, or things to think about from a tangible standpoint, is that the idea of safe space, right? So if you're thinking from an identity of being LGBTQIA, you can, it's just through simple symbols of hanging a pride flag, having a pin, having a lanyard that shows that your allyship. If you're a manager or boss, then something about how do we create a team of psychological safety where everyone's voice and perspectives are feeling heard. If you're on the kind of committee of recruitment or part of that process, you can make sure that you're advocating for unique perspectives and I think from the retention standpoint, there's so many layers where you can, and it's always, I guess in my quote that I sent you too, it's always so daunting because it's such a big topic. And so I always advocate for people to find something that is interesting to them, that is something that they're passionate about, and then always look at it from like an equity lens. And then how can you, engage your colleagues and those around you to kind of create this open space for people to ask questions and give their perspectives.
Thank you so much. Unfortunately, we are over time, so I have to move on. So I'd like to welcome up Jessica Hudson and Chandra Gordon for the next set of talks. So Jessica Hudson is the Clinical Research Engagement and Equity Senior Lead at the CF Foundation, and her take-home equity message is ensuring CF care, CF research, and the CF community are equitable is not extra work, it's core work, and should be at the center of all we do. And then Chandra Gordon is a pediatric CF social worker at the University of Kansas Health System, and her take-home equity message is strive to learn more about the diversity of the lived experience. Be open to getting outside of your four walls in your immediate community. Meet people from diverse backgrounds. Go to cultural events. Don't drive around diverse communities. Volunteer in them. Differences does not mean division. We are all joined together through shared humanity, and with respect, empathy, and understanding, we can make the world, healthcare, better for all.
Awesome. Thank you. Awesome. So we'll jump right in, and thank you to the chairs for inviting us to have this talk and share a bit more about what we've heard from communities of color around engagement barriers. This is the NACFC disclaimer. I'm CFF staff. So a quick overview of what I'm hoping to cover, what we're hoping to cover today. We'll start with just a general understanding of why health equity matters in CF, and then we'll talk a bit about listening and partnering and some of our efforts to date. And then we'll dive a bit deeper into what we've heard from people of color in the CF community and how we're scratching the surface of starting to act on some of those pieces, and then we'll end with a call to action. So I will not try to top Dr. Pittman in her health equity talk, which was amazing, but it's always good to set the tone, at least for this talk. So I'll read the beginning of this definition that says, health equity means that everyone has a fair and just opportunity to be as healthy as possible. And this image, I think, always does a great job of explaining the difference between equity and equality, where we see equality means everyone receive the same intervention, but that does not solve the problem. Whereas in equity, each individual receives the intervention that they need according to their specific needs, and then that solves the problem. But one correction here is that justice would be removing the fence, which would be bringing down some of the structural and systemic racism that we know to exist. So why does health equity matter in CF? We know and have known that CF affects people of many different racial and ethnic backgrounds. However, we have dismissed these stories in the past, and because we have dismissed these stories, we don't currently have adequate recognition or representation of people of color in the CF community. So it's a privilege to have access to stories and experiences of these individuals, and these stories can teach us how to do better, but we have to be willing to listen. So I'll start with the overview of some of our efforts to date, and then again dive deeper into what we've actually heard from people of color in the CF community, and provide a few tangible examples of some of our work that we've started in this area, but we have a lot more work to do. I'll just start by saying that. So we started in the spring of 2020 doing some listening work, and we started with one-on-one interviews with people who were already engaged in our work, people of color that were already engaged, to really inform our overall engagement strategy and start to understand what those gaps were with some of the diversity of our programs. In summer of 2020, unfortunately, we know that the world, or the country and the world, got a view into some of the systemic and structural racism with the public murder of George Floyd, Breonna Taylor. And as we wanted to kind of push that work forward from the foundation, we did launch a large survey in summer of 2020 to really get a pulse check from the full CF community, more specifically people of color, to understand what engagement barriers exist. And when we say engagement barriers, we're thinking about barriers to care, research, and being involved in our communities. In summer of 2021, we wanted to dive deeper into what we heard in that survey, so we conducted focus groups with people of color in the CF community. And we utilized these focus groups to, again, dive deeper into those themes, really understand what experiences folks were currently having that were leading to barriers, and where the stem of some of those trust barriers exists. And from those focus groups, 3 major themes emerged, which were representation, resources, and education, and that's how we'll frame the rest of the talk today. I'll also highlight that we have to partner with these communities in order to do this work. And so also in summer of 2020 and ongoing, we did develop the Racial Justice Working Group, which includes CFF staff, external advisors, as well as people with CF and parents of children with CF, to serve as equal partners and contributors to this work ongoing. So jumping into some of what we've heard from these communities, and starting with representation. When we think about visual representation, we heard that there's a lack of representation across CFF platforms as well as staff. So when we say platforms, things like websites, study flyers, webinars, and staff, including CFF, care, and research teams as well. And we know that this lack of representation has often led to feelings of isolation for people of color in our community. When we think about equity and inclusion, we know that at times, many times, representation has felt more like tokenism rather than actual inclusion. We know that people of color that have participated in some of our committees and work groups have experienced poor culture and more tokenism, and some explaining having these instances where they're expected to speak for a full community. We also heard that there's a need for more support groups and safe spaces to connect with individuals with like identities, again, to help with some of those feelings of isolation. When we think about newborn screening, across a lot of our qualitative work, almost all of the individuals that we've worked with have experienced either delayed diagnosis or misdiagnosis, and a lot has attributed to stereotypes or disparities in the screening process. So what are some of the steps that we've started to take in that space? Benchmarking of care and research teams is slated for next year. We have to understand our baseline in order to start to make a difference. We've developed best practices for inclusive committees and work groups. So those that lead our national committees and serve on our national committees now have guidelines to ensure those are inclusive spaces. We've launched CF Circles, which is a virtual platform for people with CF with like identities to come together. We've taken steps to ensure our community conferences are more inclusive. We also have a ERJDI email list, which provides a space for folks to opt in and receive ongoing updates of our work in this space. And we've also put together a newborn screening working group, which includes parents of children with CF that have experienced delayed diagnosis. So what should you consider as far as representation as a care team? Of course, the diversity of your team and the diversity of your patients and how that affects the care of your patients. And also safe spaces for your patients. We know that it can be isolating, obviously, to be a person of color in this community. So what safe space can you connect these individuals to? So throughout the presentation, I'll include some quotes from these individuals so that you can hear from them in your own words for the sake of time. I'll read this first quote here that says, "I have felt isolated and ignored. My experience and culture as a Black person seems to have been disregarded as a factor in the CF community." So moving on to improved resources, when we look at screening and post-diagnosis, we've heard there's a need for additional and improved post-diagnosis resources. So many sharing stories of receiving a diagnosis, which we know through some of the screening process has already been a traumatic experience, feeling like they're left on their own to figure it out. There's a need for more information on the signs and symptoms of CF to help some of these parents advocate for themselves and for their children in these instances. We need more educational materials to address things like vest access, nutrition, available treatments. And not only do we need additional resources and materials, but we need to ensure that there is appropriate access to these materials. So we can't stop at our highly engaged individuals receiving these resources. We need to make sure that they're reaching everyone in our population. So some of the steps we've taken here, newborn screening guidelines are underway. Again, some of the work from that newborn screening working group that includes people or parents of children with CF. We've created additional educational resources and ensured that we are sharing those far and wide. We now have a clinical trial navigator. This is a new role at the foundation, Katie Howe, and she really acts as a support system for patients and families and research teams as well to really kind of play the middleman and provide answer questions, provide additional information about clinical research. We've translated many of our materials into Spanish and are continuing to do so, and we also now offer a community voice in Spanish as well to again ensure that we are providing opportunities to the full community to get involved. So what are some things you can consider about resources? Are your patients and families connected to these new resources? How can you ensure that you're caring for the whole person and ensure they have access to as many resources as possible? And if you are sharing resources, are you doing so in an equitable way? So additional quotes here regarding resources, and I will read this quote at the bottom, which says, "When my son was diagnosed, you just find out your son has a life-shortening disease, and you're given a book and a bag with papers in it, but it's kind of like you're left on your own. Good luck." So last, looking at education, and this one is a little bit more straightforward, there is a huge need for training. Right, so we need more cultural sensitivity training, cultural competency training, bias, microaggressions, and we know this because we heard many negative experiences that our people with CF, people of color in the CF community are having. And this is important because a lot of times we attribute some of the lack of trustworthiness or lack of trust to historical mistrust, but these incidents are happening now and today and are ongoing. These experiences are happening with care teams currently, with chapter meetings and across the board. So we have to be vigilant of that and make sure that we're trained to ensure that we're providing equitable care. So some of the actions we've taken in this space, the foundation launched a health equity video and discussion guide. So this is a really important video. I hope you all, if you haven't had a chance to take a look, it's cff.org/ourcommitment. You can find that video. And it provides a really great baseline understanding of health equity, the disparities that exist in CF, and what are some of the steps we need to start to take in that space. So really encourage everyone to take a look. And we have a discussion guide that accompanies that video if you'd like to discuss more with your care team and dive deeper. Also want to highlight the PEP team here. The PEP team has done a great job creating a lot of resources and training around trust, having trusted relationships, bias, microaggressions, a lot of trainings in that space. So please take advantage of those PEP resources. And this last quote here that says, "My child did newborn screening. What they found, they blamed on my breastfeeding. If the nurse or doctor is telling me don't worry about it, I'm not going to worry about it. A month later, your child is dehydrated, showing all the symptoms. I don't now know how to rewire that." With that, I will pass it back over to Chandra.
So I think most of the speakers throughout today have really touched on implicit bias, and so I'm not going to go specifically on this slide as is written, but I want us to just keep in mind that we have biases. They keep us safe. It's a part of who we are as being human beings. But our biases also create those unsafe moments and unsafe encounters that we also have with others. So as we think about this need, and I'm going to say need, to really take that inward look into how we become more aware of the things that we do, the things that we say. And so we're going to talk a little bit about that here specifically. So, wrong way. All right. So one of the things that I'm hoping that the information that Jessica just shared was just really showing how we can really look at how we can definitely have a different view on how we can correct our biases, is really getting the personal narrative. And then through a personal narrative, that means that we're getting to know an individual. So when we take the time to understand, to be able to individuate a person, we see the person for who they are and not based on our biases. So what I like to say is that, again, we all have a story. Again, we heard earlier in this presentation, we all come to this conference as a privileged care provider or care member or family member, but understanding that there are many times that we are in different roles. So we are privileged and we can also be marginalized. And when we think about those different roles in which we play, either personal or professional, they have the ability to, I would say, reinforce our negative biases, or they have the opportunity to help us learn from our biases. So when we talk about the work that we're doing today, I'm coming and bringing it from a standpoint of this is just human nature. We have to humanize healthcare because that's who we're taking care of. And it does start with us. It does start with our own internal ability to unlearn some of the things that we've learned. So we have to reframe. We have to show empathy in order to address equity. We have to think about the things that we can do, and it comes from self-examination. It comes from humility. It comes from a growth mindset, practical things. I know we're at a medical conference. Everything that we talk about most of the time is very critical, clinical, technical. But the things that we're talking about today has nothing to do with that area of life. We're talking about the everyday lived experience. So when we think about how do we do it, it doesn't take rocket science. What it does is it takes intentionality, our ability to listen, our ability to be intentional in hearing what we need, hearing what people are sharing. It takes being voluntary in the process, not passive, not just hearing and moving forward. It takes the ability to slow down in the healthcare that we do in order to listen. And so as we begin to think about that, there's ways that we do it. Simply ask an open-ended question. Be able to engage with our parents, our family members, our coworkers, because what I'm presenting today does not just apply to the patient-provider experience. We're talking about the lived experience. So when we ask questions, impact, how has this affected your day-to-day life if we're talking with our patients? If we think about ideas, what would be helpful in this situation based on what you currently have going on? How do we even ask about expectations? It's my role as a provider to provide care for you. I have the book knowledge, but you have the lived experience. So how do we come together and create expectations together? And then we also have to acknowledge the fact that implicit bias impacts our overall mental and well-being, especially those that are on the other end of that. So how are we asking about the emotional impact that these things can happen in our day-to-day lives? So how do we engage? Again, we've talked about it, a lot of things have come up, but it's simple. Let's honor and acknowledge what has happened. We can't continue to pretend that it did not happen. We can't continue to pretend that it does not happen. We can't continue to pretend that it will not happen. We have to acknowledge the lived experience. We have to show respect and openness to understand perspectives. Just because mine is different than yours, that does not mean it has to be division or strife. It's a perspective. We have to seek opportunities to gain a better understanding of different cultures. If we only stay within our four walls, if we only stay within our own communities, we are not understanding cultural diversity. We can go to different cultural events. We can go through neighborhoods that we may fear or have been labeled certain, but understanding that everyone that lives there is not what we envision. Avoid stereotyping. That's in what we say and what we write. How we write notes about our patients also tells a narrative and creates a false narrative a lot of times that perpetuates stereotypes and biases in the way that we write our notes. Seek to understand and respect the magnitude that biases have on people's lives. We live it. And also, see that person as an individual, not a representative for all with similar and lived experiences. As Dr. Paula said, the minority tax, or whatever you want to put before that tax. There's many different people with diverse experiences that come from similar walks of life, but that does not mean they're all the same. But even thinking about not only our own individual efforts that we can do, but really working to transform informal and informal norms when it comes to our work settings, or even in our own personal circles. Again, when we think about healthcare, a lot of times we put markers on race, but there's so much more to the diversity of lived experience. How are we also looking at how we can look at how health outcomes impact that, thinking about the social determinants of health? And then also, when we think about hierarchy in our system, we got to think about diversity, equity, inclusion, just as we shared when it comes to diversity in the workforce. How are we working to create more cohesive and diverse and welcoming and inclusive work environments? How we can be intentional about that. So I want to just say diversity is a fact. We can't get around that. But inclusion is a choice. And so everything that we've shared today is really about how do we make the decision to be a part of the work and choose to do what we know is right for humanity. So I want to give a plug again for PEP. I am a PEP facilitator. But again, if you haven't had a chance to take the PEP course, we definitely encourage you to do so. It does provide practical tips and skills to be able to have these conversations that sometimes are very challenging. But again, we encourage you in PEP, let's lean into the discomfort and learn from that. There's also discussion aids and also community learning groups that are also aimed at, again, how are we partnering and how are we developing trust in our within our care centers, and I'll let Jessica share about some other resources.
So really quickly, I think we heard today it's important that we continue to partner with these communities. So I did want to share about the Community Voice program and do a plug. We have to continue to partner and include the patient voice into everything that we do. And we have a mechanism to do that, and that's Community Voice. So we really, really encourage you to share Community Voice with your patients. We're relying on you to ensure that Community Voice continues to grow in diversity, and to ensure that things like our care guidelines, clinical trial design, include the diverse voice of our community. So please share, and happy to talk with anyone more about that. And also, we're gearing up for our long-term strategic plan at the foundation, and we currently have a survey live. We would like to have your perspective and the perspective of your patients. So if you go to cff.org/LTSP survey, please, please, please take that survey and share with your patients. And that is available in Spanish as well. That is it. Open for questions. Okay.
I can't believe that you guys haven't asked one question, Jen. Thank you for asking the one question. Don't make me call on you. I know a lot of you.
So I actually have a question about the workforce issue. I'm a pediatrician, and I think that a lot of us do know that there's less and less medical students choosing to go into pediatrics, such that the most recent match, approximately 30% of programs did not match. So if there are less pediatricians, that means there are less pediatric subspecialists to take care of the CF community. So I am curious as to those who are on the panel, if that happened to your program at your institution, what are you doing about the workforce? And this has nothing to do in a way with diversity, because just overall, we just don't have enough pediatricians coming through the pipeline. And as you guys have pointed out, the existing pediatricians who have taken such a great job taking care of these kids, such that we have now more adults living with CF than peds living with CF, they're retiring. So, I'll take
Dr. Espadas. And also, thank you so much for your bravery coming up to the front. Round of applause.
Yeah, thank you. Thank you for the question. Okay. I encourage you to go to the Workforce Symposium tomorrow. Well, there'll be a lot more detailed discussion about the workforce.
Thanks, Liz.
Maybe I'll just put it back over here then after that. I don't know. I think to Dr. Powell's point that we need to start our recruitment efforts in general earlier. I think more so this will be discussed in the Workforce Symposium tomorrow, but a lot of things that came up from our survey respondents that would encourage them to get into pediatrics would be if reimbursement for taking care of pediatrics was more on par with caring for adults in medicine in general, and then other sorts of inducements in that way. But for our trainees, we found that if you can loop them into mentorship, if you have them attend NACFC, that was associated with a higher likelihood of being interested in making CF as a focus of your career. So I think loop your trainees in, include them as part of your efforts, and that might be a first step because there's ways that we could improve that.
Yes, I completely agree. The only other thing I would add was just from a practical standpoint, whenever I'm in inpatient rounds, I'm always exposed to medical students as well as residents. And so I always make it a point that at some point during the week, I sit down and kind of give a good pitch about how fun we are, how interesting we are, what a great lifestyle we have, things like that. And so because there is a lot of data to show that early exposure and having a mentor and creating an inclusive environment will encourage people to come into the subspecialty.
Do you have a comment, Jess? Pediatricians also are among the worst paid subspecialty or specialties, which is a big deal.
I will also say that while that is totally true, and this is also, it is a pathway issue and it is a diversity issue. We know that medical debt has become, or I should say educational debt to go through med school has become overwhelming for many folks. And so there is an aspect of privilege in going through medical school. And then many folks who don't have privilege need to go into subspecialties or specialties that pay more in order to make up the $1 million of educational debt that they've accrued. But we also know that folks who come from marginalized backgrounds are more likely to go into fields that care for marginalized patients. And so pediatrics, particularly general pediatrics, is one of those specialties, right? So folks from marginalized backgrounds are actually more likely to make choices against their own financial interest to care for their communities. So again, if we can address pathway issues, if we can figure out, which we know how to do it, we need to improve our educational system as a whole throughout this country. But if we can get patients, or we can get kids through school with good education into college, interested in medicine, it's a long pathway, but that's how we build more pediatricians.
Go ahead, Marcy.
Marcy Sontag, Center for Public Health Innovation, and I'm really here because I was afraid Dr. Laguna was going to call on me rather than coming up and volunteering on me. No. I spent a lot of my career at this Colorado School of Public Health where we had the same problem, right? The diversity in the workforce problem, and we'd get accreditation and they'd say, you need to be more diverse. Like, yes, we do. And you look around who's graduating from graduate schools and undergrads, and it's just exactly as you said. So we started a program partnering with neighborhood schools in middle school and high school, and over summers had come to our campus, school kids who typically they're from minoritized populations wouldn't have these opportunities to show, here's what you could do in public health. We brought in people from medicine and just had those fun experiences. Again, similar to what he said earlier, trying to make sure, hey, we're fun, we're cool, this is great, and you're smart, you can do this, because we have to start early. We have to empower individuals to come up from middle schools and high schools from underserved populations who can then go to college, and we can't find them when they're graduating from grad school if they don't go to grad school or college. So just a kind of a double tapping. It's not really a question, more than just I really emphasize all the work you're doing, and we all need to engage. This is not just those of you in the front of the room, we all need to engage in our communities.
Thank you, Marcy. Appreciate it.
All right, so last but certainly not least, I'd like to welcome Dr. Megan McGarry, who is an associate professor of pediatrics at the University of Washington. And her health equity take-home point is that a path to health equity depends on you taking personal responsibility to create change in your own clinic and research.
Good afternoon, everybody. All right, so I don't have any disclosures financially. I definitely am not going to be speaking for the CF Foundation, and this is not their views. My disclaimer is that some of the content presented is going to be sensitive, and you may be feeling uncomfortable and distressed by how we have been treating the Hispanic CF community. And that this talk is going to be discussing how each advance of the CF community has not benefited the Hispanic CF community equally. And by the end, I hope that you feel outraged that there's not been action on this. So we'll be going through CF centers and the CF Foundation, clinical trials and the TDN, newborn screening, lung function, Pseudomonas and other pulmonary pathogens, and CFTR modulators. The Hispanic CF community is growing. So overall, about 10% of the CF community identifies as Hispanic or Latino. But in children, it's much higher. So 15% of the infants diagnosed last year were Hispanic or Latino. But why is the Hispanic CF community growing? Well, the Hispanic population in the United States is growing. It's the fastest growing race or ethnicity. But there has been, over the last decade, increased detection with newborn screening so that diagnosis then became dependent on what was screened versus who providers were deciding to refer and diagnose. And really because we have been overcoming the incorrect racist biases that have really prevailed throughout medical education, research, hospitals, and even here at NACFC, where over and over and over again, this incorrect racist lie being told of that just discussing only that it's the non-Hispanic white population with CF. And everybody else was erased from the narrative. And that turned into people forgetting and erasing that so many other people have CF, including the Hispanic community. So to talk about CF Foundation, so amazing work. We're created by moms, by scientists and researchers who saw these children dying and that they developed the CF Foundation. The problem was that they were centered in academic institutions that were segregated. So academic institutions, medical institutions were segregated historically and continue to be, many academic societies like the CF Foundation and ATS and other medical institutions did not allow researchers and doctors who were Black or Hispanic to participate. Black and Hispanic patients with CF were not allowed to go to these hospitals, to these academic institutions. And so instead of being described in the literature and diagnosed and treated, they instead were erased from the whole historical narrative and they were left to die and suffer on their own. So when we look at the CF Foundation and we look at CF clinical trials, we know that about half of papers describing CF clinical trials don't even bother to describe the race and ethnicity of the subjects. Of those that do describe, this is the yearly, the percentage of subjects who were identified as Hispanic. And you can see that most years, 0 papers were published that even had one patient that was Hispanic in them, and never ever representing the overall CF population. So to take a little step back, who is this population that we're talking about? You may have heard Hispanic, Latino, Latina, Latinx, Latin, and really this is a very diverse group that are all tied together by experiences, by language, by identity, that span from across the world. Hispanic is a term that I am using for this talk because that is what the registry and most of the research has done. But this is a very European-focused description about Spanish colonialism and really erases the rich indigenous and African contributions and people in the Latino community. And because this community is so diverse, they come from across the world, it is no surprise that their CFTR variants are also diverse. So these are different studies of Hispanic or Latino populations from different locations, and you can see that their genetic frequencies are very different. While all have Delta 508 as the most common, you can see that it really ranges, and that certain groups have variants that are common that don't even occur at all in other ones. And and then this is showing that in just people who are in the CF patient registry in the United States, they ranked the top 50 most frequent variants by race and ethnicity. In the Hispanic community, 40% of the top 50 variants were unique only to the Hispanic community and were not in the top 50 for any other race. Whereas you can see it was only 8% of the variants were unique to the non-Hispanic white community. And this is really important when we're thinking about newborn screening. So newborn screening over the last over 10 years has really improved diagnosis. This has not benefited all groups equally. So the ACMG panel was one of the major panels that was used with the uptake of newborn screening. It's important to know that ACMG was not designed for this. It was designed for prenatal screening for women who were non-Hispanic, white, European background, or Ashkenazi Jewish. That's the variants that were included with it. We unfortunately took that panel and then applied it to our overall CF population. So you can see overall it would detect one variant in 93% of our CF population. But in people who are Asian, it's about half. So it only detects 3/4 of people who are Black with CF and about 80% of people who are Hispanic. Why have we been okay with this over the last decade? Why are we okay with such a low detection, way below any of our benchmarks? And this is really translated to a much higher proportion of false negative newborn screens, shown in the blue, than the overall population. So you can see Hispanic in this group was about 9%. The false negative newborn screens, they were about 15%. And then the delayed diagnosis that was over 6 months old before they were diagnosed, Hispanic was 25% of that group. And so you can see that, that these inequities really transferred over from our poor choices on the tests that we were using. So we have, if you have not heard yet, new CF newborn screen guidelines, because there's no guidelines or recommendations at this point for any newborn screening program. These will be the first CFF guidelines ever to take into account health equity. And one of the main things is that we're recommending that programs should aim to reach 95% detection of infants across all ancestral groups. So this is not just looking at your group overall, but actually looking at the different races, ethnicities, ancestral groups that are in your state to make sure that you are detecting them all and they're being diagnosed. And we are recommending screening for all pathogenic CFTR variants in CFTR2, which is about 1,100. Because how is it ethical to know that a variant is definite disease causing and then choose that it's not important to screen for? So to move on to, there's been amazing improvements in lung function, where now children and adults have normal lung function. Unfortunately, lung function disparities are horrible in the Hispanic population. So even when we control for all the factors, exposures that have been shown in the non-Hispanic white population to determine lung function, Hispanic populations still have a 5.3 percentage points lower FVC, 5.7% lower FEV1. And here, or not here, on the West Coast, I forget where I am right now, it's 9 percentage points lower. How have we been okay with this? We have known this for a decade now, and there has not been action on this. There's been huge improvements across the CF community on respiratory microorganisms. So if you look at the blue, that's Pseudomonas, and you can see since 1992 to 2022, that has really rapidly decreased. Unfortunately, Hispanic people have a much greater increased risk of many pulmonary pathogens. 26% increased risk of any Pseudomonas, 59% increased risk of mucoid Pseudomonas, 91% increased risk of multi-drug resistant Pseudomonas, 19% increased risk of MSSA, 13% increased risk of MRSA, and even ABPA, the prevalence was twice as high. Most of these infections, they also acquired at an earlier age, and yet there's not been action on this. CFTR modulators, we all know, has been an amazing advancement, and because that they were not included in clinical trials, people who are Hispanic, their variants were not the ones approved. While 92% of non-Hispanic white people with CF qualify based on their mutations, only 3/4 of people who are Hispanic people qualify. And it's even worse when you look worldwide. When you look at the other countries, it's mainly European white countries that have approval and access, while countries that in Latin America and other Hispanic Latino communities, those are the ones that do not have access. Mortality in CF has improved, and this is probably the most amazing thing, that it went from a disease where children who were dying to when I started over a decade ago, where people were dying in their early 20s, to now where people are living and thriving, having children, and growing to adulthood. But this is not the same for their Hispanic population. Hispanic CF community has a 27% increased risk of death. The mean age of death is 6 years younger, and yet we still don't have action on this. But why? So there's many things why, and we could be here all day, and I could teach you all, and maybe next year we'll do that. But today, we're just gonna target a few things. So this is a language interpretation study that was done not in CF, but in emergency rooms. And they told people what they were doing, and they videoed encounters in the emergency room in pediatrics. And then they just recorded the amount of time that interpreters were used. And this one compared video interpreter in the pink, phone interpreters in the blue, and you can see that about for all communication that occurred during the ER visit, it was only 50% was interpreted. When it was provider-led communication, where the provider was doing the talking, then it was only up to 60%. But when we broke it down by like specific activities in that ER visit, you can see that updates, so medical updates, how the child was doing, it was less than 40% of the time that they bothered to use an interpreter. But meds, vital signs, the physical exam, and procedure were 10% or lower. And then you can see the plan was only 60% of the time. So if this is what's happening in an emergency room visit with high acuity, when they're being recorded and told what's going on, what are we doing in our CF clinics? And how are we not communicating properly with our patients? There's been a lot of talk about diversity of physicians, and so I'm going to move along. But the main thing to realize is that our pediatric pulmonology workforce does not represent the US population. It does not represent our Hispanic CF population, and we need to work better on this. Our institutions are untrustworthy, and this is from historical things as we talked about, but also ongoing. And this is really, you need to understand this when you're thinking about our Hispanic CF community and why they may not want to show up at your door or participate. So last year, a Tennessee hospital gave over to the government all the records of their transgender clinic of everybody who'd been referred or seen without notifying their patients. Your records are not sacred, they are not protected, and we need to realize that. And patients know that we are not trustworthy, that these are not private information. A few years ago, the government tried to deport children who were here on visas legally with life-threatening illnesses, including with cystic fibrosis, and other children with life-threatening pulmonary diseases, including, I know this because I found out about this in the ICU with my own patients. And then we'll know that many institutions across the United States have disbanded or barred diversity, equity, and inclusion task force. Our patients are seeing this. We are not trustworthy to them. There is also, this is just from this last week. So this is the environment that our patients are living in, is prevalent racism. And these statements that are said get repeated in the community, and unfortunately, they get repeated in our medical institutions. And this is so traumatic, and this is what our Hispanic CF community is living with right now. Hundreds of migrant children remain separated from this family separation from over 4 years ago. It's almost 1,000 children still are not reunited. I don't know if I would show up for a research study or to clinic if this is what I was facing. And so what we need is action. Voting is a social determinant of health. And we need to vote because on the line for this year for our Hispanic CF community is insurance, it's newborn screening, it's the right to live without fear and racism, it's education, it's NIH funding, it's medication access, it's FDA funding. And so we need to not only vote, we need to use our voices because people need to hear how this is going to affect our community. We need to stand up for them, and we need to fight like hell, and we need to work on this. We talked about the racism and discrimination experienced by our pediatric pulmonologists, which is our people in our room, how we're treating them. But how are we treating our patients if that's how we treat our colleagues? We know that our biases are harming our patients. Discrimination and racism very much directly disrupts healthcare. 70% of those who experienced racism said that it disrupted their healthcare. Half looked for a new doctor, which good luck with that in many places trying to get a new CF doctor, right? Half delayed their healthcare, and 40% just went without. So maybe we need to be really taking a step back and thinking, what environment are we making our patients walk into? We've talked a lot about these quotes, and I think this is to continue to bring it back to our patients. Oh, you have CF? You're not white. You have to be on the brink of death before being diagnosed because of the persistent stereotype of it being a Caucasian disease. The resources didn't include Hispanics, didn't include Black women. The underlying reasoning was it was not that important. Nobody else in the room said anything when I mentioned we should be included. Nobody said a single word. It's assumed to be a white disease, and that if you're lucky, you get to live to 54 and get diagnosed, or you're dead and no one even knows that you had it. We need to listen to this community. We need to care about this community, and we need to change because it's alarming that this is horrible stats, horrible things that are happening to them, and yet we do not have action. Just to remind you, CF centers, clinical trials, newborn screening, lung function, Pseudomonas, and CFTR modulators. I dare you to find an advance that has not benefited them equally. And so we should pause and remember all the Hispanic CF community that have died because of this, that suffer because of this. We need to remember them, and we need to commit to change so that they can live full, thriving lives. And we're not going to get what we don't fight for. These are not going to change without us doing something, us in the room changing it. Otherwise, we'll be here in another 10 years doing the same descriptions. Our patients are counting on us. And of all the forms of inequality, injustice in healthcare is the most shocking and inhumane. So I thank you for being here, and I urge you to go back and to act. Thank you so much.
Yep.
All right. Thank you, Dr. McGarry. So we are running short on time, so we're just going to open it up to if anybody has any questions for any of us or any comments or stories to share, please feel free. Hopefully that mic works now. Go ahead.
Hi, this is Debbie. I'm from Southern California. Megan, you spoke to my heart. I've experienced so many and witnessed so many Hispanic patients that have not had the opportunity, and it's really devastating. And I'm so glad that you're bringing this up, because I know I've been telling the CF Foundation for Hispanic material that's not readily available. We've now hired nurses, a dietitian, and a social worker who are Spanish speaking. It makes a world of a difference. Even when we had pamphlets for when the modulators came out and we were talking about the different kinds of things that they need to eat, well, those aren't things that the Hispanic community is eating. And so we modified and created our own material because those don't exist for this population. And so I hope that your story today is really going to spark an energy for us to be able to help this community. So thank you so much.
There was one question online. Georgine, do you want to read it?
So someone was asking, how would you go about asking patients why they would prefer not to participate in research studies, thinking REACH study?
Yeah. So I think the problem is that this is the question that comes up first. Why won't they participate? And the question really needs to be is, why have we created an environment that they don't want to be involved in? And I think that the main thing is to step back and go, it's our work to be done, not them. And I think that thinking about, do you have somebody who looks like them that's in the research clinic? Is it even in their language? And really take a step back and thinking about, like, well, what has their experience been interacting with clinic, in the hospital? Do you know what it's like? Are they anxious about coming in? Is it a good experience? Or is mom having to be in the hospital room protecting them from having something done horrible to their child? And I think it is really knowing your patient. Like, what happens if they run out of gas on the way there? Are they worried that they're gonna run into an immigration officer? What's going on at home? Can they afford to take time off? Can they do all these things? And I think really stepping back and working on that regard. I think if you're not having conversations about research with them, about what's coming up, then maybe that's the place to start. Because in their clinic visits, if you're only telling them, well, here's a research study I want you to be involved in, versus educating them about their CF, about their medications, about what's coming, and like creating a back and forth environment where you understand what they're interested in and what their goals in, you're not gonna get them to participate, so.
Dr. Wyatt.
Awesome talk, Dr. McGarry, so good. So just with the rise of COVID happening, there was so much decrease in in-person interpreters and actually giving time in our clinic spaces to have interpretation. Do you have any advice on like how to advocate to the hospitals and making our voice heard that this is like so important to have?
Yeah, so I like to file incident reports, whichever way you might have it called at your hospital, every single time that the video interpreter doesn't work, because that's such a failure on it. You have to collect data on that kind of thing, and you have to bug it because the administration is just looking at costs, and in-person interpreters cost a lot of money. And so I think it is outlining the importance for it, using the studies that have been done to really show the need for it. And yeah, it's quite difficult though, because I think that is one of the things that got cut, and then they've realized they don't need to bring it back, so.
We have another question online. How can those of us who live in states that typically vote against racist and discriminatory legislature advocate in states where these policies are voted for and enacted?
So one is raising your voice. So social media is across all states, so you can speak out. Two is to not assume that you are in a blue state and this is not happening. We'll say, for example, newborn screening. Some of the best advances for newborn screening for expanding panels have occurred in quote unquote red states. Well, some of the blue states have had the most limited. And so don't assume that because you are in an area that you don't, that there's not something to fight for, something to advance in. But we all have friends. Your friends are here. So we all have people who live in those states. So to think about how can you ask them what they're doing to encourage them, and that kind of, yeah.
Okay, so we hope that this is just the beginning of a conversation. All of us will be hanging around afterwards, so if you have questions, please come on up. I'm going to end with just a few kind of take-home messages for the group. I think you've heard this theme throughout all of our talks, is to continue to reflect on what you've heard. Where do I have room to learn and to grow? Listen when a patient, family, or colleague gives you feedback. Learning how to incorporate when somebody calls you in. How do you listen to what they're saying, and how do you learn from that, reflect, and grow? Providing equitable healthcare in an inclusive and safe environment requires every single one of us. It's not just the people who belong to minoritized communities. It's not just the patients who are minoritized. It is every single one of you. And leaders in the room, what can you do as a next step? We have the opportunity, as having a platform, as having control-ish over budgets, over priorities, over where our resources are spent. So how can we set the tone? It's up to us to be able to decide where we're going to prioritize things. Hopefully all that you've heard today just emphasizes the real work that needs to be done and how we can all work together to try to make all of that happen. And I know that there is CF Foundation leadership in the room, so I'm going to specifically call them to action and to continue this conversation. Somebody mentioned, this is one room. This is not a plenary. This is not the whole group. Everybody needs to hear this. These are messages that everyone needs to know. So how do we do that? How do we get this beyond everyone that already has, for the most part, bought in? You're sitting here, so you believe in this stuff and you're going to try to make this work. But what about the other 4,800 people that are out there attending this conference? How do we get this message to them? So you have people who are willing to work together to do that. So take advantage of us. Let us get the message out there, and let's work together to do this better. So thank you to everybody for attending.